A bit about the mechanics of breathing. Now that we've described our pressures, we've talked about their values, some of the examples. Let's talk about the mechanics. Movement of air in and out of the lungs happens because of our pressure gradients, especially the intraalveolar pressure and how that compares to the atmospheric pressure. And so we'll also talk about how the Boyle's law comes into place, how the volume change can then influence the pressure change, and then we can have bulk flow of air. So the forces for airflow, which is our pressure gradient, one and the same, right? That is based upon atmospheric pressure, which is pretty much constant. If you are in the middle of your breathing cycle, you're pretty much in a fixed atmospheric pressure or atmospheric environment. So that number really isn't changing, which is another reason that we don't want to think about its actual value. It's much easier to just consider its relative value as zero. So the alveolar pressure is what is changing. Okay, the atmospheric pressure isn't changing much. Instead, the alveolar pressure is going up and down to change the direction of that gradient and move air either in or out, respectively. Boyle's law is what describes this relationship. It says that pressure is inversely related to volume. Okay, when pressure goes up, volume goes down, and when pressure goes down, volume goes up. So we don't have to change the pressure directly. Remember, this is sort of a passive process. Instead, we can change the pressure by first changing the volume. And then we also talked about resistance here. This resistance is going to impede flow. This can be due to things like the airway radius, which becomes important with things like asthma. Asthma obstructs the airway, especially the bronchus. And so as that airway gets smaller, it impedes flow, and that can be resistance to our overall driving force for flow. Another factor that causes resistance, we said, is mucus, which is also seen with asthma. So asthmatic patients have both of these factors working against them. They have a smaller airway diameter because of inflammation that actually creates a thicker lumen and blocks some of that flow. And then on top of that, they have mucus, which is another response to inflammation in the airway. So both of these things will impede flow and are considered resistance. So if you look at our overall flow equation here, it's going to be a little bit different than what we described in the vasculature, but same principle. Bulk flow is equal to our pressure gradient. In this instance, our pressure gradient is our atmospheric pressure, usually constant, minus our intraalveolar pressure, which is what is doing the changing. And that is divided by resistance, any impedance to flow, the radius size, which can increase resistance, and the additional mucus, which can increase resistance. Now, in terms of this value, the intraalveolar pressure, this is going to be changing owed to Boyle's law. We'll talk about how the volume changes first, this changes second, and then we can change the direction of our pressure gradient and drive flow either into the lungs or out of the lungs. All right, another law that we need to sort of think about that has application with this is the ideal gas law. The ideal gas law says that pressure, which is the pressure of any gas, and volume, which is the volume of the container, is equal to these three constant values. N, which is the number of gas particles in moles, R, which is a universal gas constant, so this is also constant, and that is 0.083, and then T, which is the temperature, which is also usually pretty constant. So in this ideal gas law, PV equals nRT. The N is usually constant, at least it is in our scenario here, we'll talk about. The R is a universal constant, and then the T, the temperature, is also constant in this instance. So the pressure and the volume are the two variables that are moving. And so if you look at our scenario here on the left, we have a container that is larger in volume. So our volume here is equal to 2. We have our number of particles, which is constant. So it's the same number of particles in this container as it is in this container. Temperature is also the same in this container as it is in this container. So again, we can ignore these three variables because they are constant. However, because the volume of the container is higher or greater, the pressure is lower. So with scenario one, container one, volume is equal to 2, but pressure is equal to 1, right? Half that pressure for the same amount of volume. Comparing that to container 2, now we have a smaller container. We simply made the space or the volume smaller. And now we see that volume is 1, so half the volume, and now pressure is double because we decreased the volume. So this is what we mean by Boyle's law as well. Pressure is inversely related to volume. As the volume gets greater, the pressure decreases, and as the volume gets smaller, the pressure increases. So we can sort of extrapolate this knowledge, right? We can take this information and we can apply it to our lungs. If I wanted to drive air out of my lungs, okay, I would need to have a pressure in my alveoli that was greater than the pressure in the atmosphere, okay? And so in order to do that, I could indirectly manipulate the pressure by first manipulating the volume. So all I would have to do is make the size of my thoracic cavity, right, smaller, which means the pressure would go up, and now the intraalveolar pressure would be higher than the atmospheric pressure, and air would move out. And the opposite is true. If I wanted air to move in, I would manipulate the volume, the size of my thoracic cavity first by making that larger. When that becomes larger, pressure goes down, right? Inversely related. So now my intraalveolar pressure is less than, because it's dropped, it's less than atmospheric pressure, and now air can move in. So I don't need you to memorize this equation or even be able to use it in any sort of, actual calculations. But what I do need you to understand is how it applies to that, right? The inverse relationship between pressure and volume, and how we can change the shape of our thoracic cavity first, which is manipulating its volume, and then we can, as a result, change the pressure and drive our bulk flow in one direction or the other. Let's talk about the determinants of the intraalveolar pressure, right? We said that the intraalveolar pressure is the only pressure that's really changing or moving. Atmospheric pressure is pretty constant. And then intraalveolar pressure is sort of following the change in volume. So the factors that determine the intraalveolar pressure is the quantity of air. How much air is that person breathing in? Or how much air already exists inside their alveoli. The other factor is the volume of the alveoli, right, which is determined by the shape of the thoracic cavity. So these two factors will manipulate our intraalveolar pressure, make it either smaller or greater than atmospheric pressure, and then that can drive our bulk flow. In terms of the lungs expanding, the alveolar volume here is going to increase, which makes sense, right, as that air comes in. Well, actually, the volume expands first, then the air comes in, okay? And so the intra-alveolar pressure decreases, and the pressure gradient is what drives air into the lungs, all right? So don't think about it as the air moving in is what makes the volume bigger. It's the other way around. The volume gets bigger first, and now the pressure goes down, and now the air can move in. So the air doesn't make the volume change, the volume makes the pressure change, and the pressure drives the air. So it's really kind of, again, a chain of events. And if we disrupt any of those variables, this is why, for example, if someone had a respiratory distress, or if they had, let's say they had a neurological disorder where there was paralysis to their diaphragmatic muscles, and they couldn't physically change the volume, that alone could impede airflow. They can't expand the thoracic cavity to increase the volume and drop the pressure. That can be very dangerous, and that can lead to respiratory distress, right? They won't be able to manipulate the volume simply because they can't contract the muscles. And another example here is when the lungs recoil. This is involving a decrease in alveolar volume. So the thoracic cavity gets smaller first, then the intraalveolar pressure goes up, right? Volume goes down, pressure goes up, and now we have a higher intraalveolar pressure, and that can simply drive air out of the lungs. Higher intraalveolar, lower atmospheric, the gradient favors expiration or exhalation. Okay, so here is a schematic. I'm just reiterating this in several different ways. It's a very important principle. Inverse pressure to volume. We're manipulating the volume first, then the pressure follows, and then the bulk flow according to that gradient. So here's an example what happens during inspiration. Here is our airway. Here's our alveolus and the air particles or molecules inside. Notice how when the alveolar pressure is zero, there's no airflow because we don't have a gradient. Atmospheric pressure is zero, and if alveolar pressure is also zero, there's no flow, there's no gradient. Alternatively, when we have a drop in our alveolar pressure, okay, because of an increase in the thoracic cavity volume. So the muscles contract. Remember, when the diaphragm contracts, it actually flattens down. So flattening down of the diaphragm is when it contracts, that makes the volume of the thoracic cavity physically bigger. Volume goes up. As volume goes up, pressure goes down. Now the intraalveolar pressure is -1, it's less than atmospheric pressure, and now air can move in because our alveoli are distended or inflated, okay? Here again, we're at rest. This is in between our respiratory cycles, so we have inspiration, then zero flow, and now we have expiration, the other end of our respiratory cycle. The opposite is true here. As the thoracic cavity gets smaller, now we relax the diaphragm and it curves up. So when the diaphragm is contracted, it flattens down, thoracic cavity gets bigger. When the diaphragm relaxes, almost the shape of this curve here, the dome-shaped curvature projects up into the thoracic cavity, and now the thoracic cavity physically gets smaller. All right, so the volume goes down, pressure goes up. Now we have +1 millimeters of mercury as our intraalveolar pressure, and now we can have airflow. This time it's going to be out of the lungs as they deflate, okay? Higher pressure inside the alveolus, lower pressure in terms of our atmospheric pressure, which is zero. Now we can drive air out. Okay. So what is changing the shape of the thoracic cavity? Just to reiterate which muscles specifically. During inspiration, we have the inspiratory muscles. These increase the volume, which is essentially the size of the thoracic cavity. This includes the diaphragm, which becomes flattened down, as well as the external intercostals. Remember, external intercostals are down and in. So what they do is they pull the cavity up and out. So because of that, both of these muscles makes this space larger, which increases the volume, thereby decreasing the pressure, and you can have airflow in. Contrary to that, intercostals, the internal intercostals that is, and the abdominal muscles, such as our rectus abdominis and our abdominal oblique muscles, they are going to decrease the volume, i.e. the size first. That increases the thoracic pressure, and then now air can move out from the alveoli into the environment. Okay, so our rectus abdominis, our other abdominal muscles, along with our internal intercostals. And then our internal intercostals are opposite. So they go down and out, which means that when they contract, they can make the thoracic cavity smaller, the opposite of external. So here are some of these muscles. We would have talked about these in lab already, right? So our inspiratory muscles being the external intercostals, right? Sort of interleaved or interdigitated or, interspersed in between the ribs. The diaphragm itself, which is probably the most important muscle here. It's going to be more curved and dome-shaped when it is relaxed, and then it's going to flatten out and increase the thoracic cavity when it is contracted. And then our expiratory muscles, our abdominal obliques, our abdominal muscles, such as our rectus abdominis and our external oblique, internal oblique, as well as our internal intercostals. So here, notice how the size and shape of the cavity changes first. When the chest wall and the lungs expand, right? This expansion moves the sternum up and out. So the sternum kind of moves up and out like this, almost like a tap, right? A tap handle. And the ribs move up and out like this, almost like a bucket handle, right? If you look at the handle of a bucket, the ribs move out like this, the sternum moves up and out like this. So that makes the entire space physically bigger, the contraction of these muscles. The diaphragm also goes down, flattens out, which further enhances that. And then expiration, the opposite is true. We have the contraction of these muscles, the ribs and sternum depressed, so the ribs come down and inward. The sternum also comes down and more posterior, and then that makes that space physically smaller. The diaphragm curves up and kind of relaxes on itself, which projects up into that thoracic cavity. And then just to point out the internal intercostals and then the rectus abdominis muscles, these are usually only engaged with forced expiration. So if you're in quiet respiration, let's say you're just breathing in and out, passively, you're in a relaxed state, you don't really engage any muscles for expiration. Expiration typically is a passive process. When the diaphragm recoils and relaxes, that is usually enough to stimulate the change in the cavity to drive air out. But if you were to be in respiratory distress, right? Let's say you have, I don't know, a pneumothorax or a punctured lung, right? Now you're going to want to have more forceful changing of the shape, and now you're going to engage these abdominal muscles, your rectus abdominis, etc., to really drive that change. So this is more for active or for forced contraction to bring about forced expiration. Okay, so let's talk about the sequence of events, bringing in here the neural stimulation. So remember that these muscles are innervated by the nervous system. So that plays a huge part in what triggers these muscles. So during inspiration, we have nervous stimulation of our inspiratory muscles, such as diaphragm, which is innervated by the phrenic nerve. This causes the muscle to contract and flatten out or move downward. Similarly, the intercostals, which are innervated by the intercostal nerves, causes the ribs to pivot up and out, right? Kind of flailing up and out to expand the chest. Together, these things increase the volume, and then they also pull on the pleura. So because of those two forces, the intrapleural pressure and the transpulmonary pressure, intrapleural pressure dropping, remember that must be negative or lower, and then the transpulmonary pressure increasing as that negative intrapleural pressure drops. So the lower this intrapleural pressure goes, the higher the transpulmonary pressure goes. Remember, transpulmonary pressure is intraalveolar pressure minus the intrapleural pressure. So as that number gets more negative, transpulmonary pressure increases. So that increases the distension pressure, the ease with which the lungs want to distend. The alveolar also expand because of the drop in alveolar pressure, and then air simply flows passively according to bulk flow. All right. Now, just to wrap up here, I just want to reiterate Boyle's law here. So let's kind of draw this out, and then we will pick up the rest on Wednesday. So let's just describe and summarize what Boyle's law means and how we can apply that. So we're talking about the mechanics of breathing, and and specifically how Boyle's law influences that. So let's start by describing what Boyle's law is. So Boyle's law says that for a given quantity of air, in a specific container, right? In this instance, the container is our thoracic cavity. Pressure is inversely related to volume. That is to say that when the volume goes up, when the volume of our container gets bigger, such as when the diaphragm relaxes, okay, that is going to decrease the pressure in the container. And the opposite is true. When the volume of the container goes down, that is resulting in increase in the pressure in that container. Okay. And so just to summarize this here, you want to think about the volume changing first. Okay, you may see this worded in different ways on your questions, but essentially, pressure changes in response to volume change first. Okay. And then what's driving this are our respiratory muscles. So our respiratory muscles and I'm going to put in brackets here, diaphragm and the external intercostals, they help to increase the size, while internal intercostals um, will help to decrease. Okay, so just to give some examples here, I should have written this out, but hopefully you get this. External intercostals and diaphragm increase the volume, and then internal intercostals will decrease the volume. So this is essentially the respiratory muscles changing the volume first. Okay, and then the pressure changes as a result. Now I'm feeling compelled to rewrite this so it's a bit more clear. So let's rewrite this here. So inspiration, which is conducted by the diaphragm and our external intercostal. These two result in increased volume and decreased pressure. Alternatively, expiration, brought about by our internal intercostals. And I say internal intercostals mainly, but also remember we can have with forceful expiration, Our abdominals, not as engaged at rest, but they can help. And they do the opposite. They decrease the volume, and as a result, increase the pressure. Okay. So let's make this a little bit more clear here.